Thank you for joining. We're going to get started in just a few minutes. Hi, everyone. Welcome to tonight's conversation about reproductive health. My name is Edna Ulysses, and I'm a volunteer for Haitian Ladies Network's Program Committee. I'm based here in Washington, D.C., where I currently serve as a policy staffer in the United States House of Representatives. The Haitian Ladies Network began in 2007 and is the largest global platform of Haitian women and girls with over 100,000 members. Tonight's conversation about reproductive health falls in one of our 5 pillars anchoring the Haitian Ladies Network and our year-round programming, which includes wellness and healing, financial well-being, bridging Haiti and its diaspora, culture and heritage, voice and influence, and voice and influence. And now I'll hand it over to our lovely moderator for tonight's event, Dr. Nashley Harrigan.
Hello, everyone. Hi. I am Dr. Nashley Harrigan. I am one of 10 board members of the Haitian Ladies Network. I am also a board certified emergency medicine physician in New York City. I got my degree at the University of Miami. My focus is on women's health. I'm part of the New York Health Women's Alliance, the Women's Health Initiative. I help do women's research at Yale, and this is right up my alley. So, one of the things I wanted to share with everyone and why this talk is so important is because I get a lot of you guys coming into my emergency room daily on a very, very regular day where you guys come in to get blood transfusions from being severely anemic from fibroids. You guys are coming in from exposures to STDs and STIs. You guys are coming in complaining of severe pain from fibroids, from endometriosis. And I realize that we do not understand what's going on with our bodies. So I called a couple of friends to come in and talk. And yes, they are Haitian, and I'm very excited to have them here. So, one you may recognize is Dr. Suzie Armas. She is a distinguished healthcare executive, physician, public health professional, philanthropist, author, and motivational speaker dedicated to health and well being of the underserved communities. She is president and co-founder of New World Health Foundation and served as chief operating officer of New Health Community Center. She got her medical degree in 1993 at the, forgive me if I say this wrong, Facultad de Medicina de Universidad Autonomía de Puebla.
Correct.
Yes. She then got her bachelor's degree in physician assistance and master's at Nova Southeastern in Florida. She is dedicated uh, impact of HIV. She has worked for the University of Miami and Miller School of Medicine and Jackson Memorial Hospital. She is an HIV specialist. She has done forensic. She's been a forensic examiner and worked at the Rape Trenter Center at Jackson Memorial Hospital. So thank you for coming, Dr. Armas. We also have with us Dr. Sherley Samuels, who is a first generation Haitian American board certified OBGYN in Covenant, women's health specialist in Covenant, Georgia. She has over a decade's worth of experience caring for women throughout their reproductive years. She is proud of her Haitian heritage. She's passionate about empowering women through education, addressing disparities in women's health, and improving their health equity. Dr. Samuels is also the founder of Women's Health Leadership Initiatives, where she mentors future physicians and helps prepare the next generation to recognize and address inequities in the healthcare system. So welcome, ladies.
Hey, thank you for having us.
I know that was a mouthful. So let's start. Let's get started. I am here to help moderate. I will be asking some questions. The first question I actually want to talk about is with Dr. Armas. What have you been seeing in some of your community centers? What type of complaints, what type of problems have been coming in with your women population?
Hello, everyone, and it's such a pleasure to be among a group of young ladies and young professionals. And I'm very thrilled to be tonight and sharing my knowledge with you, my experience for the past 29 years. And it is sad to see that we still go into the same issues over and over, and we have not learned that much, and we have not reached the higher understanding about reproductive health. What I have seen in my, or what I have not seen in my ladies at the centers, and what I have not seen at the University of Miami and at Jackson Memorial Hospital. The fact that we know that pain is normal for us. We are in pain and we don't seek help. That is a problem. And we wait until it's too late when we get to the emergency room. And it has to be like a surgery or something major. This is the reason why a talk like that is so important to share with our ladies.
Thank you. Dr. Samuels, why are fibroids so disproportionately affecting Black women? Why do they find out so late? What exactly are fibroids? And can I get rid of them from just eating different foods? Is it something that I did?
Gotcha. Yeah. Hello, everyone. And Nashley, thanks so much for putting this together. I'm super excited to be here. As you mentioned for yourself, this is right up my alley. So I'm super excited to be here. So fibroids are tumors. They are benign tumors, but tumors nonetheless. And what tumors do, or the major characteristic of tumors, is they grow. They rapidly divide, the cells rapidly divide, and so they get larger and larger and larger. Now, because they are benign tumors, you don't necessarily have to bother them unless they bother you. However, they tend to bother women frequently. And so we have a whole host of different treatment options that I'll be happy to discuss throughout the panel. Why do they disproportionately affect Black women? About somewhere between 60 to 80% of Black women are going to be diagnosed with fibroids by the time they reach the age of 50. And there are probably numerous factors leading to this. Number one, just biases in medicine lead to later diagnosis and diagnosis of fibroids when they are much further along. And that's typically because symptoms are not believed or heard when women bring them up. But the reason why they are present is probably multifactorial. It's probably due to a genetic component. Probably due to an environmental component, possibly exposures to different things, maybe even social stressors. We don't 100% know why fibroids develop, but we do know that they are very, very common. Most women will experience them, and Black women are more likely to be diagnosed with larger fibroids and more severe symptoms than non-Black women.
I would like to just add to what Dr. Samuels just said. Demoiselle, toute demoiselle captain Demio, vraiment m'ta remè que nous comprendre ça qui passé là. Parce que fibrome, quand Dr. Samuel so dit, fibroids ou bien léomyoma, c'est problème femme haïtienne. Pour qui ça me dit ça? Parce que pendant 29 ans de carrière, moi wan pile femme haïtienne, moi wan pile l'autre femme, m'ka dou que m'jwenn seulement 2 jamaïcaines qui gen fibrome. Quant à pour haïtienne, si yo pa gen 36 fibrome là ou opéré yo gen 26, yo gen un gros qui grosseur un ti moun 6 mois, You name it, we have it. The reason why, as she said, multifactorial. Pour qui ça, nous pas connaît. Est-ce que c'est manger n'a manger yo, ou bien est-ce que nous manquons faire sexe? On pas connaît. C'est ça qui fait, on challenge Dr. Samuel and Dr. Harrigan, since they are doing public health. We need to do some studies about the Haitian ladies and fibroids. Even though, si nous avons fait une étude rétrospective de 10 years, I can bring all my patients, your patients, Dr. Samuel, and Dr. Harrigan patients, in one study so we can have numbers dans la communauté pas noire. Parce que yo mettez nous dans noir, mais nous-mêmes nous uniques. We are Haitian women. And fibroid is part of our lives. Et mais que ça change. Et pour ça changer, nous devons donner, nous devons faire études. Et challenge là, c'est vous-même avec Nashley Map Target.
Yeah, I'm glad we are making sure everyone gets not just the Creole, but the English version as well. So thank you, Dr. Armas. We appreciate it. Can you, while we're here, Dr. Armas, can you talk about preventative screenings? What should I be getting routinely, annually, every couple of years? What does that include? Vaccines? Does that include a pap smear? Like, what exactly should I be doing?
I would like everyone to take notes about what I'm going to say because it's very important. Et puis, en pile, moun pas comprendre que screening, c'est prevention. Ou voulez prevent au lieu de guérir. Ou pas laisser le maladie arriver, c'est le ça pour courir. Donc, pour cela, I would like everyone to understand, if you are a young lady and you start having sex, when I ask someone, are you sexually active? Yo toujours dit non. Le mot sexually active, I am not asking you if you had sex last night. And your answer is no. I'm asking you if one in your lifetime, a penis has entered your vagina. I am sorry, I have to speak clear. If the answer is yes, this is what you're going to do. We need a vaginal exam, which we call Papa Nicolao, or bien pap smear annually. And if that test is normal, and you have not changed partner, ou ete avec même ménage là, ou bien toujours avec même maria, nous gen droit pas refaire test là annuellement, nous ka fait chaque 2 ou 3 ans. Si gen un bagay pour ajouter, Dr. Samuel a pas ajouté ça, parce que yo fait des changements dans screening yo qu'on y a là. Ça, c'est pour pap smear. Si ou c'est une jeune fille, if you are a young girl, you start with your period. I always encourage ça. Chaque fois ou gen règle, toucher sein ou toujours apprendre yo comment pour yo checker sein yo parce que si gen un problème dans sein, c'est ou même ka premier monde qui pour faire docteur a connaît. Qui problème ça yo kaye. Li gen droit peut-être un petit boule dans sein, just a little mass in the breast. Li gen droit changement de couleur, coloration changes. Ou li gen droit texture, li gen droit texture sein changer. Donc, si ou est 3 bagay sa yo, you will be the first one to tell your doctor or to tell your parents, something is wrong with my breast and I would like to be checked. Number 2. Number 3, if you turn 40 or even 35 nowadays, they would like you to have a mammogram just to make sure about breast cancer. Not to go any further about sexually transmitted diseases because HPV is a biggie in our community. I encourage tout parents pour yo ta ki fait ti moun yo prend HPV vaccin. M'pa besoin connaître ça gouvernement parler konya là. Nous même let kaye casse tête nous. Préféré nous prend vaccin nous pour nous pas porter la porte cassée parce que HPV cause cancer dans col matrice, li cause cancer dans anus, li cause cancer dans bouche parce que nous gagnons tout type de sexe yo dans la vie. Puis gars nous comprendre que c'est là kay moi seulement c'est oral sex happen or anal sex happen. It happens everywhere and it is happening in your house and it is time to screen so we can get the numbers right?
We are getting
I would
distracted.
just like to jump in on the screening. So with the pap smears, we recommend starting at age 21, and that is irrespective of sexual activity. Once you turn 21, you should have a pap smear. Also, talking about the changes in screening, there are some guidelines now talking about screening every 3 years to 5 years. I like to explain to my patients that those guideline changes were made to save money, not made to save lives. So I recommend pap smear once every year, period. While monogamy does, or low risk activity typically puts you in the category where you can get your pap screens done less frequently, you can really only be accountable for yourself. And so you can't assume that you have not been exposed to HPV. So again, I recommend not only a pap smear once a year, but STD screening once a year. I have been married for 14 years and I get my tests every year. Now, I know one thing, they better come back negative, okay? Or there's going to be some problems. But once a year, you can only be accountable for yourself. Number two, I did want to bring up the colonoscopy, which should start at age 45. That age used to be 50. We've dropped that down to 45. A lot of people were huge Chadwick Boseman fans after Black Panther. We know that he passed from stage 3 colon cancer at age 43. So 2 years before he would have even gotten screened, he was already gone. And colon cancer is another big, it impacts our community wildly. And so I really want to encourage people to get their colon cancer screening via colonoscopy. Now, some people are going to say, I don't want a camera up my butt, right? I don't want to do that. I want to just do the test where I poop in the bag and I send it in and they screen it. But to touch on Dr. Armas's point, do you want something to prevent colon cancer or do you want something to tell you you have colon cancer? That's the difference between the two. Colonoscopy screens for, looks for polyps, removes them before they ever become cancer. The Cologuard poop test, that tells you if you have cancer. So again, a colon cancer screening is absolutely recommended for our community, and it's done once every decade, once every 10 years. You could do anything once every 10 years, right? It's not like it's every year like the mammogram. So that's the tidbit I wanted to add on the screening.
Thank you. I appreciate it. One of the things that I see a lot are very young women who come in with debilitating pain, especially that first day of their period. I get told a lot, that's just what my mom had, my aunts had. It's just, something that we go through. We just have very painful periods. This is it. Can you help me? Give me something. And then I'm back in, back to work, back to school, back to everything. Is that normal? Should I really be in so much pain I cannot function that first day? What should I be telling my doctors about that level of pain that I'm experiencing and what could it possibly be? And this is to both of you guys, actually. So, Dr. Armas, if you want to take it first, or Dr. Samuels, if you want to take it first, and then Dr. Armas, you could follow.
Yeah, so first, I want to just preface this by saying every woman experiences menstruation differently. And so determining what is normal is a little bit tricky because what's normal for one person is not normal for the other person. However, debilitating pain to where you cannot function, you cannot perform your normal activities throughout the day. You have to miss school, you have to miss work, or heavy periods that you're passing clots and soaking your clothes, and you have to pack extra clothes with you in your car and extra supplies. That would not be considered normal. And those are all reasons that should prompt you to seek care. And I hear it all the time as well. This just kind of runs in my family. But these are the situations when we finally get them in and we do an ultrasound. We're finding fibroids the size of a cantaloupe. We're finding numerous fibroids. And, these things don't start that large. They take years to progress. So I definitely want to empower any woman, if you are not able to perform your normal functions during your cycle, seek care. It could be due to fibroids. It could be due to a hormonal imbalance. It could be due to polyps. It could be due to, a misfiring or a misalignment of ovulation. I mean, there's so many different things that could be causing that. It could be a thyroid disorder. You might just need a thyroid medication to get the periods back on track. But there's no way for us to know what's going on if you don't take yourself in and get evaluated. And I'll let Dr. Armas hop in.
Ça m'ta remè fait tout le monde connaît, c'est que ça, Dr. Samuel dit, c'est ça, mais m'ta remè faut connaître que it's okay to ask for help. It's okay to go to the doctor. It's okay to speak out. Piga ou honte, piga ou gêné, parce que petite la gen 12 ans, petite la gen 10 ans, li commence gen règle, et puis pour honte pour ça. Non. Before, like in my mom's time, pas gen toute technologie sa yo, nous pas gagner choix à tout docteur sa yo que nous gagne aujourd'hui. But today it's different. Pas krete la caille et puis pour nous petite la gen douleur pour balte. On pas dit que t'es pas bon. It's good to have the home remedies, but the home remedies cannot replace the doctor's medication or the doctor's guidance. M'a dit ça en créole, tant pris souple, pas bay ti moun antibiotique parce que gen règle c'est pas une infection, gen règle c'est un bagay normal la kay toute femme. Donc, si petite la gen règle, après règle, li tant pris pas bali antibiotique que n'a pas acheté sous comptoir ou bien antibiotique qui sorti dia pour ne pas répéter non, pour ne pas prendre un problème. Chaque haïtien gon titi wala kayo avec antibiotique que yo acheté, tant pris souple, nous pas besoin antibiotique, le nous gen règle. Et si ti moun gen en douleur, si ti moun a vomi chaque fois que li gen règle, si ti moun pas ka kembe kol, si ti moun gen la fièvre, li pas normal. Donc, tant pis, mener ti moun nan kay docteur pour le ka connaît qui ça le gagner pour nous ka joindre solution pour lui parce que douleur pas fait partie de nous-mêmes. Même si nous comprenons que nous doués souffrir, mais m'a dit nous journée jodia, souffrance pas fait partie de la vie normale de on fille, il pas fait la vie normale de on moun, period.
Thank you. I know there are some very triggering words or hot topic words right now. One of them is endometriosis, PCOS, perimenopause, menopause. I would like to touch on some of them, giving some of the definitions. What are they? What should I be asking my doctor? Dr. Samuels, if you can start and tell me what exactly is PCOS and endometriosis that I've been hearing about recently in the news. You're on mute. You muted yourself. Sorry.
There we go. There you go. So endometriosis and PCOS are two very different diseases, very different disease processes. So endometriosis, what that essentially is basically the endometrial lining or the part of the uterus that gets thickened every month, and then we shed it with a cycle, and then it gets thick again next month, and then we shed it again. Those cells escape the uterus somewhere or the other, and they end up places where they don't belong. And that causes an issue for women because those cells respond to hormones. The reason why we have that thickening and that shedding is a hormone cascade that I'll be happy to explain. But those cells respond to the hormones no matter where they are. So if they're outside of the uterus and in the abdomen, they're going to thicken and then they're going to shed. If they're on your bladder or on your rectum, that's going to happen, and that can cause significant pain. Other symptoms that you can see with endometriosis are going to be infertility. That's the number one reason why people come to me for management of endometriosis, but also significant debilitating pain, painful cycles, and things of that nature. Then you have PCOS, which stands for polycystic ovarian syndrome, recently renamed to polymetabolic something syndrome. I have to try to remember the new word, but it has been recently renamed to try to kind of describe and incorporate all of the different things that occur in a woman's body during this disorder. But essentially what happens with PCOS, or let me backtrack, what happens normally every month? Normally every month, a woman makes 1 or 2 cysts on each ovary. And then your brain picks one and says, you are the special one this month. And that cyst is going to grow to about 2 centimeters and release an egg. That egg is going to hang around for about 5 days and wait for sperm. If there's sperm present, you're going to make a baby. If there's no sperm present, you're going to make a period. And then that cyst and that egg will go away. And then next month, we're going to do it again. Sperm, baby, no sperm, period. And then next month we do it again. So that's the process we go through every month from the time we're 12 and we have our first period until we're 55 and we don't have periods anymore. What happens with PCOS, which stands for polycystic ovarian syndrome, so the definition's in the name, polycystic multiple cysts. Instead of making 1 or 2 cysts on each ovary, a woman might make 10 or 15 or 20. And what happens is that confuses your brain because your brain says, hey, I am not meant to have a litter of puppies, right? I'm not meant to release 10 eggs. So you know what? I'm not going to do anything this month because there's just too much going on here. So we don't release an egg that much. Remember, only 2 things happen after releasing an egg: sperm, baby, no sperm, period. So with PCOS, you're not able to get pregnant because there's no egg for the sperm, but you also miss your periods because remember, the egg disintegrating is what leads to a period. So the biggest concern or complaint that women come in about with regards to PCOS is that they're missing cycles. They'll say, hey, doc, I've gone 6 months or I've gone a year and I haven't had a period. And the reason is typically due to PCOS.
Dr. Armas?
I'm just back on Dr. Samuel. Ta reme tout moun kompren sa yo l'endométriose la, c'est yon bagay en Haïti qui très commun. Tout temps de moun nan di, I'm looking at you, I'm not seeing myself, Nashley. I don't know why. So, can you hear me? Because I'm seeing you, I'm not seeing, okay.
Yep, we hear you.
Ça passe, c'est que OK, en pile moun en Haïti toujours dit que yo pral faire un curetage parce que ça très commun le moun arrivé yo joine que endomètre là endomatrice là un petit jan épais et puis docteur Avoye là le fait un curetage rentrer nettoyer utérus là pour qu'a préparer pour l'autre cycle ou bien pour l'autre petite. Ça très commun en Haïti. Donc on bagay moi t'a remet toucher c'est que today's date everybody is on the internet. Everybody knows everything. Everybody comes to you with an article. Oh, I have PCOS. Oh, I have endometriosis. How do you know? Oh, I received that. Look at this. Look at that. You need to know that YouTube has no real information. So, pas quitter YouTube là, mener on côté koto pa ta vle rive. YouTube a bay information pour tout le monde qui a connu, pour tout le monde qui a fait l'argent. Moi, ta remen djou, si ou que ou gen 6 mois, 1 an ou pas gen règle, tant pris, allez kay docteur. Tant pris, sous senti que règle la trop ou tellement gen heavy period, ou allez kay docteur. Pas garder ça YouTube a dit parce que YouTube pas kaba ou santé. Un seul gens pour joindre santé, c'est si ou al kay docteur pour docteur a évaluer et puis pour le kadou qui traitement que li kaba ou. Mais ça m'a dit pi bonheur c'est grand matin. The earlier you go, the better it will be parce que nous capable joindre solution pour vous. Mais sou vini trop tard, pas gen rien n'a ka faire.
Thank you. What about perimenopause and menopause? I know that is definitely something that's been in the news recently. It is another hot topic that everybody's bringing up. What should I know about menopause? What should I know about perimenopause? And what I don't know, what should I be doing? Why am I going through this?
So, a couple of things. Menopause is defined as 12 months without a period. Once you have gone 12 consecutive months without a period, you are officially menopausal and you should never have a period again. If you start bleeding after menopause, that is a reason to go to your doctor and request evaluation. Now, the period stopping for 12 consecutive months, your body just doesn't wake up one day and say, all right, that's it. I'm stopping. That's, all things are shut down. The office is closed. What happens is maybe 10 or 15 years before you ever get to that 12 consecutive months, you start making less and less hormone every year until you will eventually stop completely, and that'll lead to menopause. That 10 to 15 years or so of making less and less and less hormone, that's considered perimenopause. So you can be perimenopausal from the time you're in your early 40s until you stop your period at 55. Perimenopause and menopause are natural states. They are not things that necessarily require treatment. This is a part of life. And I think that we definitely need to wrap our minds around that. And in one aspect that I feel that society does us a disservice is explaining menopause as some kind of mountain that we're going to climb and then come over on the other side, and then we're completely done. Menopause is now our new state. Just like when we went into puberty, we never went back to not being in puberty anymore. We're never going to go back to not being in menopause anymore. So that means you may experience some symptoms for the remainder of your life because now you are menopausal. Treatment should really be tailored to symptoms and quality of life. If you are having hot flashes to where you feel like you are being electrocuted 50 times a day, well, my dear, you probably need some treatment, okay? Because you're not going to be able to function very well. Right? Or if you're having such significant vaginal dryness that intercourse is painful for you, then you probably need some treatment. Everybody's going to experience menopause differently. Everyone is going to experience puberty differently. And so it's just really important that we understand A, that it's a natural state, and B, there are treatments for symptoms if they get to the point where you need them to improve your quality of life.
Ça me t'a ajouté dans tout ça, Dr. Samuel dit, c'est que nous devons comprendre que le monde dans ménopause, moun nan pas fou. Tout le monde a pensé que ménopause, c'est oh, fille a fou, madame moi fou, mes amis, m'pa ka parler madame moi agité, madame moi tout bagay. C'est pas faute li. C'est un bagay, c'est un family issues. Moi remek pour me dire monsieur a, si c'est monsieur a qui vient complaindre, moi dit il vient à madame nan, si c'est madame nan qui vient complaindre, moi dit il vient à monsieur a pour me parler avec eux tous les deux, pour me faire yo comprendre que c'est une étape que n'a passé dans la vie nous. Mais c'est pas parce que nous avons folie ou bien parce que nous pas gain compréhension. Au contraire, moi mandé Maria pour un petit gens plus compréhensif à madame nan. Parce que ça c'est une situation difficile. Moi-même moi passé monopause, ça c'est un bagage qui t'a doué apprendre que nous tout t'a doué apprendre avant même que nous t'arriver là-dedans. Et ça que Dr. Samuel m'a remis ajouter tout c'est que l'heure où moun nan gen bouffé de chaleur, soit que li vle retirer rad li parce que li trop chaud, li t'a vle jeter tout rad, li besoin mettre un ventilateur en dans li parce que li trop chaud, c'est parce que ovaire yo qu'on y a commencé à rajeunir au lieu pour m'ta dire à grand monde, ovaire yo pas recevoir message de tête là encore. Le message là vle rive, yo pli pas un côté pour l'aller parce que ovaire là pas recevoir. Donc li tout était en l'air. Li ba nous bouffer de chaleur ça yo et puis qui fait que nous voulons jeter tout rad sous nous pas connaître si nous dans mi-temps monde, nous pas connaître si nous dans un grand fête et puis nous n'a souhait qu'on y a là nous penser que nous pas sociable. Non, mesdames, c'est un moment difficile, c'est un moment non ménopause là que n'a passé. Mais ménopause, c'est un bagage naturel. Donc, on t'a remis que plus monde parle de ménopause. Là, moi, bien content qu'on y a to see that everywhere they are talking about menopause. All the stars are talking about menopause. And that is making more people aware of what we are going through. Because we have a tough life. We have de règles, and ensuite, de faire petite, ensuite, menopause. Oh my God, that is a tough life for a woman. And on top of that, we have to take care of the men. Tête chargée. So we need to make it like a family affair. Bring the husband for a talk, and why not seek some mentor or go to the social to go see for a therapist, not for treatment, but to talk about it, because it is still a taboo subject in our community. If we want to hide things, it's no longer time to hide. It's time to open up so we look for help, and so people can know that this is not normal, this is normal, and this need further assistance.
I love this. This is a family affair, guys. We're going to go ahead and open up and start asking some of the questions that are in the chat. But I have one personal question, and it's more cultural than anything. What cultural misbeliefs that Haitian women go through when they are talking about their reproductive system? What's stopping them from, going to the hospital, going to see their doctor, getting the treatments that they want, because this misconception has been passed down for generations on generations, and we kind of want to clear that up. Dr. Armas?
Yeah, I would say
Dr. Samuels, go first.
Sorry. Please, Dr. Armas, you go first.
Okay. There are so many things that have been passing from grandma to mom to us, and me to my daughters. Yon bagay ki très important, c'est le on fi pa ka fe petit. Mes amis, what a drame. Ou pa ka fe petit, donc problème nan c'est ou. When most of the time, it's not only the woman that cannot give children to the husband. Most of the time, it's the husband as well. It continues to be a family affair. Bagay sa yo toujours ap accuse fi yo. Mes amis, assez, c'est assez. We need, if the woman cannot be pregnant, I know that you go through that, Dr. Samuel, we need to bring the husband, and both of them need to go to testing, because infertility is not only a woman issue. Ça, c'est une plus gros problème. Qui ça m'a dit encore? Numéro 2, l'on parle avec un petit monde bonheur de sexe, ça veut dire ou voyez ti moun al fait sexe. Mes amis, maman, papa, tant pris souple. Pi bonheur ou fait ti moun nan comprendre corps li, comprendre importance and value the vagina. This is one word that I love in English, that they call the vagina private, to make them understand that this is their privacy, to keep it private. It is important to teach them about the sexually transmitted diseases, because many of them has no treatment, like HIV, HPV, because we need to start talking to them as early as possible. Mais, grand moun haïtien connaît que sou parle avec ti moun de sexe 3 bonnet, c'est Djoudi la fait sexe. Come on. N'a vive notre 21e siècle. On nous parle clair. C'est longtemps que tu gagné c'est petite la vini parce que c'est mené yo mené. Non. Nous connaissons comment petite la fête. Pas bay ti moun yo menti. Tonton Noël n'existe pas. Donc it's time to open up and teach our people, teach our children, so they can teach their children, so nous can sortir dans marronnage. It's time to stop the marronnage. Ladies, on troisième bagay, reproductive health is not only women, it's also men. En Haïti, depuis a parlé de bagay ça, yo serreti yo, et puis yo voye ti garçon yo al faire sexe à bon nan. Come on! Yo mene petit garçon aller dans prostitution. This is not right. It's time to stop that. This is the Haitian belief. Nous besoin pour nous suspendre ça. Parce que même gens, ou pas qu'à mener ti fille dehors, ou pas qu'à mener ti garçon en tout. Donc, reproductive health, it's not only for the woman. It's as well for the men. Go, Dr. Samuel.
Dr. Samuels.
Absolutely. Well, shit, Dr. Armas is so hard to follow because my Creole is just not there. I wish it was so I could break it down like that. But I wanted to say a couple of things as far as cultural beliefs that I've had to debunk. The first one, Dr. Armas, absolutely. 30% of infertility is due to male factor. When patients come in to me looking for infertility testing and treatment, I tell them bring their partner. We're going to do a semen analysis, which is looking at the semen. We're going to do an ultrasound. We're going to check the tubes, but we're not going to do them in a vacuum. We're not only going to check the woman, because, sir, we got to make sure your swimmers are swimming. They don't have two heads, two tails, or anything weird going on. So absolutely, that is a huge one. Another one that I have found that I've had to debunk, not only from within my patients, but within my own family. And I mean, my family is, you already know, nurse, doctor, avocat, like so many highly educated people, but still have this belief that if we take birth control and to treat heavy periods or stop our cycles, we're going to be backed up and filled with all this old blood in our body. That is not a thing. So now you all are experts. Now you all know what happens every month. We release an egg. It waits for 5 days, sperm, baby, no sperm, period. So if we take birth control to suppress the release of the egg, we can't get sperm, baby, we can't get period. So there's not a backlog of old blood that's sitting in our bodies that's going to go make us toxic and is going to kill us from taking birth control. And then the last thing would be a personal story. So I have a vivid memory of graduating from medical school. I'm in my second year of residency. I am a married woman. I've been married for 2 years. I call my father and I tell him I'm expecting my first child. And he says, "What? Really? Why didn't you wait until you were done training?" And I'm like, I am a whole married woman. I'm a doctor. Like, I've done all the things. Like, what are we talking about here? And I know it was coming from a good place, coming from a place of wanting what's best for me, coming from a place of understanding that, it's a grueling, medical training is very difficult and challenging. Um, but, it speaks to the thought of we can just keep on delaying and delaying and delaying and delaying until we're ready. But your biological clock is not going to necessarily be on the same clock as your professional goals and desires, or even your relationship goals and desires. So I would love to see in our community us start talking about fertility in a different way, talking about, looking at egg freezing if we want to delay fertility, looking at how am I going to achieve motherhood? How am I going to achieve parenthood if I want to wait until I finish this, aerospace program that's going to take 20 years. So many times I have women come in late 40s, early 50s, talking about desiring fertility at this time, not realizing or understanding how that changes as we get older. And we're watching celebrities and we're seeing the Brat and Tony Braxton or whoever else get pregnant at these later stages and thinking that, oh, it can just happen. But we're not seeing the behind the scenes of these women. And it's not their business to tell us. But most of the time, these celebrities are conceiving with donor egg, an egg from a 25-year-old, or donor sperm. And so we're just thinking, like, I could just delay this until later, So that's something that I definitely would like to see us kind of look at differently in the Haitian community so that we're not getting devastating news of, I'm sorry, but it's likely not going to be able to happen naturally for you.
All right.
Dr. Harrigan, I would like to add one more thing. We have the tendency of, if I have no symptoms, I do not need to seek help. If I have no symptoms, why do I have to go and have a pap smear? But like Dr. Samuel said, if you turn 21 and virgin, young lady, I am sorry, we need a pap smear. We need to check to see what's going on. It's not about being virgin, but it's about your health. Mais parents haïtiens comprennent, oh, mes amis, si fille a vierge, oui, pas docteur a besoin de faire test. It's about her health. Si pas de symptômes, ou pas pral kay docteur. Si pas de symptômes, ou pas besoin pap smear. Si pas de symptômes, ou pas besoin un mammogram. Si pas de symptômes, ou pas besoin colonoscopie. And when we check, it's too late. Please write them down. because it took how long, Dr. Harrigan, to put that program down?
What
It
program?
took you how long?
This webinar, it took how long to put this together? So
I have been
take
trying
it
to
out
put
and
this
take
for
heed.
like 2 years. So
Okay,
yeah.
2 years. So it's not going to happen every year or every 6 months. So take notes, and please remember, the screening is the most important thing, so we do not get a surprise at the end of the day.
All right. So one of our questions from Kanena Richardson, is there a solution to PCOS?
Yes, absolutely. So PCOS is largely centered on repairing or fixing the hormonal imbalances that are causing the issues going on. So a lot of times we are talking about treating with hormones for PCOS. However, not everybody can take hormones. Not everybody wants to take hormones. And so in those instances, there are other things that we can do. One of the, bigger advances most recently is, the GLP-1 medications, whether in pill form or injection form, to help with the insulin resistance. Um, uh, Historically, we use metformin, which is another type of medication to help with the insulin resistance that can happen with PCOS. If you're having irregular cycles and you just want to have, you want to make sure you're taking care of your uterus, but you don't necessarily want to go on birth control, we can do a very short course, 5 days of progesterone hormone, just to help you shed that lining so that it's not just kind of sitting there for 6 months to a year. We can, of course, help with fertility. Nobody wants to ever have infertility, but if you're going to have infertility, PCOS is a good reason because we can fix it fairly easily. We give you a medication to make you ovulate because you're not ovulating every month. And then we tell you when to time sex to get pregnant. So there are definitely a bunch of different resources and treatments for PCOS. It really just depends on, the state of the patient's, disease progression and what their goals are.
Okay. Will your insurance deny you if you insist on a pap smear prior to the 5-year recommendation from ACOG?
No, they usually won't.
It depends. It depends the way that
Well,
it's
Medicare. Yeah,
presented.
Medicare.
Okay. How should we as Haitian women navigate the inherent bias against us amongst healthcare practitioners? As doctors yourselves, have you found yourself advocating for patients to deaf ears? What do you say to women who feel for the healthcare system has failed them? I can actually say, let me join in. Let me join in on this one.
Yeah.
So, I actually get that a lot. And one of the things I say is that you have to be the owner of your body. You are your CEO, you are the head, you are the team, you are the participant. And so if you go to a doctor that you do not feel is listening to you, go find another one. If you go to a hospital that you feel like is not treating you properly, not getting the things that you want, go find another one. The reason being is you will get frustrated with a physician and go home. And now you're sitting on this problem from yet an additional 1, 2, 3 years. And it's getting worse. It's just getting worse, right? Something that could possibly have been prevented or treated. You have now increased your time of suffering, your inflammation, your whatever that issue is, because you became frustrated with someone who goes to sleep at night and probably doesn't even think about you. So if you feel disenfranchised, if you feel like this person is not listening to, if you feel like this is not where you want to be, it is simple. Go to the back of your insurance card, sign up for your insurance website. If you click and you log on, it will show you all of the physicians in that category that you can go to, and a lot of them will tell you how much it'll cost if you went to them. So you can easily just change your doctor, and that's what I encourage all of my patients to do. Anybody want to add anything else?
Yes, I would like to add, many patients complain about their insurances, but they come to you with some nails that cost $200. And for the visit, it's less. And I tell them, you are complaining about the insurance. Instead, I'm not, I love your nails. They are very beautiful. But I think what you are complaining of, you could have taken care of it with the $200. A patient today came with a new tattoo, and she's asking me for $180 to pay her light bill. I am so sorry. You have a new boyfriend, new tattoo, go get him to pay the bill. And so we put our eggs in the wrong basket sometimes. In today's date, there are many barlet, not real offices, not real doctor's office. There are many places that they are just making money from the government. They do not have patients. These places, they have clients. This is why I tell my patients, if you want a place where you can be seen and be treated as you would like to be, you need to go to a real office where they will treat you as a patient. And for that, you need to have patience, because at the Walmart, they have clients, but not at the doctor's office. You can choose. And please do not complain. Seek help, and you have the help, you have the money, but do not go on the nails, do not go on the long hair, and do not take care of yourself.
I just wanted to chime in that there are some things that you can verbalize to try to advocate for yourself and speak for yourself if you feel like you're not being heard. So just asking questions sometimes is enough to get that doctor to just kind of step back and say, okay, hold on here. Like, other than this one option that you've given me, what are my other options? When should I seek emergency care for this? When should I be concerned? Can you let me know? Why are you why do you feel like I don't need X, Y, and Z test? Like, you can ask questions. You don't have to feel like you just have to take whatever they tell you and that's it. You can advocate for yourself. You can ask questions. And then, yes, if you're not getting an answer that aligns with you, second opinion is a lost art nowadays. I feel like we've kind of lost that in medicine. Ask another doctor. There are how many hundreds of thousands of millions of them. Ask another one. And the last thing I want to say too, because I want to set realistic expectation and temper expectations. Remember too that sometimes not getting the answer that you want does not mean you're not being heard, because there's a plethora of information on TikTok and Google and all these different places, and patients will come in and say, this is what I want based on the research that I've done. And I say, that's not an option for you. You're not a candidate for that. And that can be misconstrued as, well, I'm not being heard. If you come in with fibroids the size of basketballs, you probably are not a candidate for minimally invasive surgery for that. And so that doesn't necessarily mean that the doctor doesn't want to do it or doesn't, is not listening to you. So we have to temper our expectations too. But again, use the lost art of a second opinion.
Thank you. Could birth control be used to extend fertility?
To extend fertility, I'm not sure I understand the question. If you mean, are you still able to conceive after you take birth control? Yes. Birth control is typically meant to temporarily stay fertility.
Can we talk a little bit about how the vulva changes as you get older? Is it true that it atrophies? Dr. Armas?
I let Dr. Samuels talk about that. Of course, with the menopause, things might change, but it depends on the treatment that you continue to give yourself, on the way you treat your vagina and your vulva. I always tell women, taking care of your face is important as taking care of your vulva. And sometimes we are not paying that much attention to downstairs. Dr. Samuel, may you add?
Yeah, absolutely. So estrogen is the hormone that we are making less and less of, or one of the main hormones that we're making less and less of, and then we eventually stop making. And estrogen is the hormone that maintains vaginal and vulvar health. And so, yes, as estrogen declines, the vulvar definitely changes and the vagina definitely changes. We get what's called vulvar vaginal atrophy, which is basically when the tissue becomes thin. It can become frail. It can become, instead of having a pink color, it's a little bit more like of a white color. The slightest bit of trauma can cause bleeding. So things like intercourse, riding your Peloton bike, walking can lead to some bleeding because the tissue it's just not estrogenized. So if someone is experiencing pain from that, dryness, pain with intercourse, bleeding, we do have hormonal and non-hormonal options that we can use for treatment.
What age would distinguish menopause from secondary amenorrhea from other causes and reasons? From Dr. Clermont. Sean.
So secondary amenorrhea from other causes or reasons like chemotherapy or post pill amenorrhea are just that. They are secondary amenorrhea. They are not menopause. They don't have the same hormone. They're not caused by the same thing. If you mean premature menopause or premature ovarian failure versus menopause, that age is 40. So anytime 40 or above, if you stop having your cycle, that is considered menopause. For 12 consecutive months, of course. Under the age of 40, that would be considered premature ovarian failure or premature menopause.
Okay. What about adenomyosis? I don't see a lot of people talking about it. What advice can you give a woman who has that?
I think that's one for me as well, unless you wanted to tackle that, Dr. Armas. But adenomyosis is very similar to, or is basically cousin to endometriosis. However, instead of those cells escaping the uterus completely and causing issues, they escape the compartment of the uterus they're supposed to be in, and they're now within the muscle layer. So we have separate compartments of the uterus, and the cells in said compartment are supposed to stay in their compartment. Once they start kind of traversing and invading other spaces, they can cause issues and symptoms. Adenomyosis has very similar symptoms as endometriosis, so pelvic pain, pain with intercourse, heavy cycles, painful cycles, infertility. And just like with endometriosis, there are a bunch of different treatment options that we could consider. The only cure or definitive treatment for adenomyosis is hysterectomy, because we cannot remove the muscle layer but leave the other layers behind in any way. The whole organ would have to be removed. However, for women who have not completed their family size yet, or women who, for spiritual or other reasons, desire to keep their uterus, we can manage symptoms with hormonal and non-hormonal treatment options.
Okay.
This is
We
one
are getting, go ahead.
reason why we need to seek help. We need to go see the doctor. If you have heavy menstruations after the age of 40, you need to seek help. It's not normal, because education. That's the key.
So we have so many more questions, and then we're just going to get to a couple more before we start wrapping this up. We didn't talk about maternal health at all. We didn't talk about postpartum depression. That is going to be a whole different conversation, a whole different webinar. However, do you guys feel that your patient population suffers more postpartum depression and have more complications during their pregnancies?
I can answer that, because I have a case at this moment. I have a young lady, 28 years old. She is a second baby, and she is going to depression. And I have noticed, maybe I'm wrong, and Dr. Samuel can tell me, when you have you are in a very good relationship, that this is the first child of the husband or of the partner, you are very in love, and like you rely on the partner. This is the moment that most of my ladies have have a postpartum depression. I have noticed that. I have to say that Maybe I'm biased, but this is something very important because the babies, maman pa gen tan pou pran soin petite la parce que she is going through depression, and many people do not pay attention to that. She's not taking care of the baby because she's not well. Because for the Haitian community, depression doit pas exister. Depression, c'est un bagay maléfique. C'est fait yo fait ça. C'est pas vrai. Donc, this is important, and this is to seek help, to go to the doctor and find help.
Yeah. I like to always, tell my patients, it's not you, it's the pregnancy, it's the hormones, it's the stress, it's the lack of sleep. There are so many things that are causing these symptoms, and it is absolutely not your fault. This is definitely still very much a taboo, specifically in our community, but across all communities. There's shame in it because you are expected to be happy. You just had a child. This is supposed to be the best moment of your life. This is supposed to be the most miraculous thing that could have ever happened to you, and you're depressed. And so it makes it difficult for women to seek help and to seek care. I have so many patients who come in and tell me, and particularly my Haitian patients, that they're experiencing these symptoms and they're open up to me about it, but they refuse to take medication because they don't want to take the medication into their homes. They don't want their partners and their moms knowing that they need a mental health medication. And to that, I say, the more we speak about this, the more we are open, and we have discourse about what causes this, and we take the blame and the shame off of the mom and put a name to it. I think the more we'll get better results. But it absolutely affects our community disproportionately.
Last two. Can we speak about IUDs? Any inherent risks for having them in for a long time? Do they mitigate any reproductive issues that we discussed earlier? So pretty much,
Dr.
can I keep
Samuel,
my IUD in for a long time?
Yeah. So,
Dr. Samuel, it depends. Okay.
Yeah. So, with anything that we do or take in medicine, there are potential risks, even the Tylenol in your cabinet. So to answer the question, are there potential risks with the IUD? Absolutely. Namely, changes to your cycles, changes to your bleeding, heavier bleeding, irregular bleeding, spotting in between cycles, things like that. There's also the risk of uterine perforation. That happens 1 in 1,000 times that an IUD is placed, and that actually happened to me. So yes, that even happens to us. And that can occur. That's basically when the IUD is placed in the uterus, but then it perforates, or it exits the uterine cavity, and it's somewhere in the abdomen. And we have to do a surgery, albeit a minimally invasive surgery, to retrieve it. So with that being said, yes, the IUD does carry risks. It's very, very unlikely. Like I said, 1 in 1,000 for that. Most women are going to be very happy with their IUDs. You can have them in for 3, 5, or up to 10 years, depending on the IUD you choose. Fertility is expected to return with all of them. This is a long-acting reversible contraception. Now, are there outliers? Absolutely. That's with birth control pills, Depo shot, any of the birth controls, the hormonal ones. There can be outliers where the period does not come back when we expect it to, and we have to kind of help that patient along in that sense. But the IUDs are an excellent form of birth control. They also can help with many other things, such as heavy bleeding. The Mirena IUD, with the 5-year IUD, is actually FDA approved, not only to prevent pregnancy, but to treat heavy periods. So if you're coming in and you're having heavy periods, clots, and you know you don't want to have a kid in the next few years, that might be a great option for you. I think the key here is making sure that we individualize the plan to the patient, because what's right for you is not necessarily right for your friend or even your sister.
Yes.
Perfect.
I am just adding to that my own experience with IUD. I had my first IUD, and I removed it after 8 years. And suddenly I was at the pool, and my older sister told me, Tati Suzie, I think you're pregnant. But I said, why? because when she looked at me, and I was 4 months pregnant when I removed the first IUD. So 4 months pregnant without even knowing. And after I had the second child, I said, you know what? I'm not going to have children yet. I'm going to put a second IUD because I loved it. No pain, no problem, and sex. Okay. So I put a second IUD. It was after 10 years, I went to see my gynecologist, and he said, I'm going to remove it. I said, if you remove it, I need you to place a second one. He said, no, you're not going to get pregnant. It's with your age. I said, no, I need another IUD. He said, no, because you're not. I said, if you're not replacing it, you're not removing it. Because my husband's sperm are acrobats. They can jump. And at my age, I can't have children. And he did not remove it. And I waited 4 more years. I'm sorry, Dr. Samuel. I was a bad patient, but I removed my second IUD after 14 years.
My goodness.
I love
So
it.
I can't, I'm like, oh my God.
to me, it's different for you. You didn't hear that.
Yeah, I'm stressed. I'm stressed.
Didn't hear that. Nobody heard that.
That is not what we're
But
advocating.
that's the reality.
Okay.
Last question, or second to last question. Can you get the HPV vaccine after the age of 50?
Yes, age constraints have been removed from the HPV vaccine. So there was a time where we were only taking it up to 26, and then we extended it to like 40, and now the age restraints have been removed from it.
Okay.
And I had to add to that because when a patient come and the test is positive for HPV, I treat, and I waited for 3 more months to repeat the pap smear. If the pap smear come back positive, I usually refer to Dr. Samuel. But it happens now, Dr. Samuel called me over the phone and said, you know what, Dr. Armas, you don't need to send them back to me. Give them the HPV vaccine. So this is the changes that have been happening lately.
Awesome. Last question. What should any recommendations on getting a health provider who, an OB, a family medicine practitioner, anyone who does reproductive health? What should I be looking for? What should I be asking? What are some of the key things that should help me make a decision on whether or not I stay with this doctor?
I always say that medicine is a little bit of a science and a little bit of an art. Certainly, when you come into a consultation with a doctor, this is as much of an interview sorts for them as it is for you. So, not every doctor is going to align with every patient. Not every patient is going to align with every doctor, and that is okay. So if you feel like your issues are not being heard or your concerns are not being heard, if you just don't feel like your spirit jives with this person, if you don't like the policies that their office holds, those are all reasons to say, okay, this may not be the right fit. You should never feel like you are, like this doctor is set in stone for you. You really should feel comfortable when you come in. You should feel like, I want my patients to come in and feel like they're chatting with a girlfriend. That's how I practice medicine. But some people don't like that. Some people want a rigid, just tell me straight up like it is, and kind of a paternalistic kind of feel. And that's just not my personality. So that patient might not necessarily, appreciate my style of practicing medicine. So just making sure that you, A, feel heard, and B, your personality kind of meshes with that doctor is what I would say.
Dr. Armas?
But to add to that, I'm going to tell you, you are going to, just like Dr. Samuel said, to a friend. And if you don't feel like there is a communication between the two of you, this is not the person for you. But let me tell you this. We need to ask questions. We need to know your social life. We need to know your sexual life so we can guide you, we can help you better. I always tell my patients that I like to be treated the way I like to treat my patient the way I would like to be treated myself. This is why I give you time, because the moment that you enter the four walls, that time is yours. I'm not in a rush, and if someone has to leave, they can leave, because that time is yours, and I need to provide the help that you're looking for. I take time. This is why my patients need to be patient. Because one thing I always tell them, you come to new health community centers because you are seeking for new health. So in order for me to provide that new health, you have to be patient.
Thank you, ladies, for joining us today. Any last comments or things you would like to tell the audience before we close this webinar? Dr. Samuels?
Yeah, I would just like to first and foremost say thank you so much for having me on. I really, really enjoyed this. This was absolutely awesome. Let's work on changing our reality of a woman experiencing something for many, many years, decades even, and reaching adulthood and realizing that that thing she experienced not only has a name, but has treatments. You do not need to be suffering in silence for years and years and years. Take this information that you got today and share it with a friend, share it with a loved one, share it with a sister, share it with an auntie. Let's open up communication so that we can improve our health. And I just want to shout out my mom because she's in the chat. Hey, mom.
Dr. Armas?
It was a pleasure spending that time with you, with the two of you ladies, and I think that should not be the last. What I would like to add is that the Virgin Mary had Jesus when she was maybe between 14 and 16, so at a very early age, which means we cannot continue to live in a bubble and think that our children are the best and they don't know anything. It is not true. It is time for parents like me that has older children to continue to teach them, to continue to challenge them. And if you have little children that are 10 years, 12 years, it's time to start that conversation. Don't wait until it's too late. And remember all your screenings. Please, your pap smear, your mammogram, your colonoscopy, and between the pap smear, we have the HPV, sexually transmitted diseases, and we order all that. So please
Mhm.
do not stay
And the bone
home. Do
scan.
not keep that information for yourself. And I'm challenging Dr. Samuel and Dr. Harrigan to do a retrospective studies about the fibroid. And maybe next time we will give you that result. Thank you for watching.
Thank you, ladies. Thank you, Dr. Samuels. She is located in Georgia and has an active practice. We will share her contact information. Dr. Armas has several practices, one in Homestead, the other one in Little Haiti. The Haitian Ladies Network thanks you guys for taking your time and providing this information to our audience. My name is Dr. Nashley Harrigan. I am one of 10 members of the board of the Haitian Ladies Network. This is a subject that was very dear to me. And like I said before, it took me almost 2 years to get this together. This is not where it ends. This is part of a series that I will continue throughout the year. You will see this one of these sessions at our conference, which is October 2nd, 3rd, and 4th. Did I get that right? First weekend in October in Washington, D.C. Tickets are now on sale. Please, please, please come out. We do very informative, not just webinars, but in-person sessions, roundtables, and it's going to be very fun and you're going to love it and you should be there. That being said, we will do several more of what I wish about menopause, what I wish I knew about infertility, and we're going to jump into the mental health space. Please join our listserv, follow us on our social media, Haitian Ladies Network, and stay connected with us. We love to hear from you. Fill out the survey that is going to be there at the end. And we want to thank you for taking the time on this Wednesday evening to take a listen to our stuff. So thank you. We appreciate it. We are very grateful. Thank you, guys.
Absolutely, my pleasure.
Thank you.